Hello, and welcome to the Ohio AAP Vision Screening Guidelines webinar. My name is Chris Peltier, and I'm a general pediatrician with Pediatric Associates of Mount Carmel. Our educational objectives for this webinar are to understand why vision screening is crucial and what disorders can be identified by performing it. We're going to compare and contrast methods of screening for visual acuity as well as ocular alignment, and we're going to recognize when it's appropriate to refer a patient to a pediatric ophthalmologist. 1 in 20 preschoolers have a vision problem, and 1 in 4 school-age children have a vision problem. Amblyopia is reduced vision in an eye that has not received adequate use during early childhood. The loss of vision is due to lack of use by the brain at a time of critical development of the visual pathways. There are several conditions that can result in amblyopia, and the most common include an unequal refractive error, strabismus, and visual obstruction. Regular vision screenings can prevent the inability to learn, the loss of quality motor skills, and self-esteem. But most importantly, when caught early, they can prevent permanent vision loss in children. But we have a lot of work to do. Only about 21% of preschool-age children have their vision screened, and an estimated 14% of children receive comprehensive vision examinations before entering either kindergarten or first grade. Why is involvement of a pediatrician so important? As you know, pediatricians have regular contact with their patients. Their parents respect and trust our medical advice. We have access to patient history and risk factors, and we serve as the patient's medical home. Regular vision assessments in early childhood can reduce the risk of persistent amblyopia and permanent vision loss at age 7 years of age by 50%. This talk really goes over 2 guidelines that were published in January of 2016 in pediatrics, and the references are listed here for you. The first is Visual System Assessment in Infants, Children, and Young Adults by Pediatricians, and the second is the corresponding clinical report, which is Procedures for the Evaluation of the Visual System by Pediatricians. And everything that we're going to cover over these next several slides can be found in these 2 publications. This is the Bright Futures periodicity table. I realize it's very crowded and very busy, but as you know, this tells us what all things we should be doing and screening for at all well child visits from prenatal up until age 21. If we look at footnote 7, you can see that Bright Futures recommends a visual acuity screen at ages 4 and 5 years, as well as an attempt in cooperative 3-year-olds. Instrument-based screening may be used to assess risk at ages 12 and 24 months, in addition to well visits at age 3 through 5 years. When looking at just the things that, over the course of a child's early life, this graph looks at what things we should be asking about and examining and screenings that we should be performing from the newborn period up until 5 years. You can see that really during all of those times, we should be performing an ocular history, as well as external inspection of the lids and eyes, and a red reflex testing. Beginning at 6 months, we should begin examining the pupils, as well as doing some form of ocular motility assessment. Beginning at age 1, we could be doing some instrument-based screening, and also visual acuity fix and follow. And then finally, beginning at age 3, an age-appropriate visual acuity assessment. And we're going to go over all of these in a little bit more detail next. So let's look at ocular history first. Questions to ask the parents are, do your child's eyes appear unusual? Do you have any concerns about your child seeming to see well? Does your child exhibit difficulty with either near or distance vision? Do your child's eyes appear straight, or do they ever seem to cross? Does your child's eyelids droop, or does one eyelid tend to close? And has your child ever had an eye injury? Family history that we should be obtaining in regards to the pediatric eye exam include asking about eye disorders such as cataracts, strabismus, amblyopia, or refractive errors, any history of family members who have had eye surgery, and whether parents and siblings have ever needed glasses to help them see. The ocular examination includes an external examination, examination of the pupils, testing for the red reflex, looking at the ocular fundus, and an assessment of visual function. The external examination would include looking at the lids, orbit, conjunctiva, the cornea, and the iris. And you're looking for things such as ptosis or drooping of the eyelid, redness or conjunctivitis, cloudy corneas, or any evidence of photophobia. When we're looking at the pupils, we expect the pupils to be equal, round, and equally reactive when using a pen light to examine. And remembering that asymmetry of the pupils may indicate ocular injury or neurologic disease. And keep in mind that differences less than 1 millimeter between one pupil and the other pupil are normal and are generally benign, unless seen with ptosis or other ocular motility deficits. When looking at the red reflex, you want to do this in a darkened room using an ophthalmoscope. You want to look at each eye separately at a distance of between 12 to 18 inches, and this helps screen for cataracts, retinoblastoma, or retinal detachment. An urgent referral is indicated if you see a white pupil, dark spots, or an absent reflex, remembering that a white reflex indicates the possibility of retinoblastoma. The Bruckner Test is using direct ophthalmoscope and looking at the red reflex to see differences between the intensity of the eyes, which can do help us figure out different things. Obviously, we can look at refractive errors. We can look at strabismus. So doing a direct ophthalmoscope is very important in the pediatric eye examination. And this is just a child with a white pupil that ended up having retinoblastoma. So that's what you're looking for. You can see in the patient's right eye, normal looking red reflex, and in that left eye, retinoblastoma. This would call for urgent referral to a pediatric ophthalmologist as well as an oncologist. You can also use the direct ophthalmoscope to attempt to look at the fundus, realizing that especially in uncooperative children in an undilated eye, this can be quite difficult, but still, to get better and to hone our skills, we should be doing this at each well child, looking for the macula and the retina and the optic nerve head. And if you have any concerns, be sure to contact a pediatric ophthalmologist. When looking at visual function, there's two things that we typically look at. One is ocular alignment and motility, and the second is visual acuity. Let's look at ocular alignment and motility first. There are a couple of different tests that can be used to assess this. One is the corneal light reflex test, also known as the Hirschberg test, and the other is the cover-uncover test. And remember that it's important to keep in mind that strabismus in the neonatal period can be normal, and I typically will not refer unless the strabismus persists past 4 months of age. So when doing the corneal light reflex, ideally, the pupillary light reflex should be symmetric in the middle of both pupils. And here you can see that the patient's right eye tends to be deviating inward with a lateral displacement of the corneal light reflex. You also notice a difference in intensity between the right red reflex and the left red reflex. The cover-uncover test is used for a slightly older child that can cooperate. You ask them to fix on an object that's behind you and have them stare at that object, and then you take an eye paddle and you cover one eye, have them fix and follow, and then you quickly swing it to the other eye, and you're looking for any deviation of the affected eye that may have been turning inward or outward. The other thing to keep in mind is pseudostrabismus. So this is actually a normal phenomenon in which a child may appear to have esotropia or an inward deviating eye. And if you look closely, just standing back, it looks like this child has strabismus, some esotropia of the right eye. You don't see the white of the sclera on the nasal bridge here, but a couple of things that you might want to notice. First off, this child has a very sort of large nasal bridge here. And when we do the Hirschberg test and looking at the corneal light reflex, you can see that it's symmetric from one eye to the other eye. So this is a child that would be considered normal and would not need a referral to a pediatric ophthalmologist. Well, what about visual acuity assessment? In infants, this can be very simply, does the child make eye contact with you? Do they follow your face? Do they smile? As children get a little bit older and reach the toddler age, we can look to see if children fix and follow. And again, using the cover, uncover test to see if you can elicit any strabismus. Older children is measured by delineating objects that are called optotypes on a wall-mounted or a handheld eye chart. You can begin as early as age 3, but that can be very difficult in an uncooperative 3-year-old. But usually the recommendations are by at the very latest age 4 to do this screening. And you want to test one eye at a time. And the things we're going to go over again are recommended by the American Academy of Pediatrics in those publications. These recommendations may, in what they require or what they're suggesting, may be a little bit different for the preschool vision screening QI program that you're doing. And so if there's a difference, I would suggest you follow the Ohio Department of Health guidelines and not specifically some of these. But these are other reasonable options that you could do in your office if you are not participating in a particular QI program. So how do we screen for visual acuity? You want to have a well-illuminated, quiet area in your office that's free from distractions. Testing distance up to age 5 is 10 feet, and age 6 and older is either 10 or 20 feet. You can also consider using handheld optotypes at 5 feet or tablets at phone at 1 to 2 feet. You first ask the child to identify large optotypes at the top of the eye chart or on the handheld cards. One eye is occluded, and lines of optotypes or cards with single optotypes with crowding bars are presented to each eye individually. And these are just some examples of some different optotypes. The most common for the preschool vision age are the Leah symbols with the house, the circle, the square, and either the heart or the apple. And this is great for kids that aren't able to yet recognize letters. Usually once kids get to be school age, we use the typical letters, like there in example A, you can see E, G, and D, H. So consider covering the non-tested eye with adhesive patch when testing children with a visual impairment. That may just help sort of their other eye from taking over and that sort of wanting to try to be able to see and trying to get around the eye cover. Only Leah and HOTV characters are recommended for preschool vision screening. And it's remembering to remind your MAs, I'm going to go back, sorry about that. Do not isolate shapes or letters inadvertently on a line or cover to help the struggling child. You want to get a fair, accurate assessment of what the child's visual acuity really is. What's the threshold line evaluation? Well, the child starts at the top of the chart and continues reading down each line until they recite the smallest line of optotypes that are discernible. This identifies the best level of visual acuity in each eye, and it allows for subtle difference in visual acuity between each eye. It is time consuming. You need to warn your staff if they've not done this before, and it can result in loss of attention, especially in the younger kids. So compare and contrast that to the critical line evaluation. This is where the age-dependent line a child is expected to see normally and pass. It's really not necessary to screen the below the age-specific critical line to pass the test. So in other words, if you know that a child should, what would be the minimal visual line for them to pass, that is where you start. And they must pass a majority of the 4 to 6 optotypes that are present on the critical line. This is much less time consuming and much less sustained attention is needing than going from the very top and working your way down. It allows you to be much more efficient and it makes it easier for the children. What are those critical lines? So for ages 36 to 47 months, that would be the 2050 line. Once they get to age 48 to 59 months, they should be seeing at 2040. And once they get to 60 months or 5 years or older, they should be either 2030 or 2032, depending on the chart you're using. So for the critical line evaluation for a 4-year-old, you would start at the 2040 line and see how they do. If they struggle, you can then go up one line to the bigger line and then work your way back down. I'm going to talk briefly about instrument-based screening and when it may be useful. Instrument-based screening can be attempted beginning at age 12 months, but many experts feel you get better success if you started at 18 months. It's quick and it requires less attention from the child. What disorders will it detect? Well, it can detect amblyopia, high refractive error, and strabismus. It does not provide direct assessment of visual acuity. And once a child can read an eye chart, either the Leah chart or the letters, the HOTV, transition should be made to Optotype-based acuity that we looked at a few slides ago. There's a couple of different instrument-based screenings that I just wanted to briefly make you aware of. The first is something called a photo screener, and it identifies optical characteristics of the eyes. It will allow you to estimate refractive error, ocular alignment, and position of the eyelids. It assesses both eyes simultaneously, and the images can be interpreted by trained operators, a central reading center, or via computer software. An autorefractor is a second type of instrument-based screening. Handheld refractors use optical methods to estimate the refractive error of each eye, looking at each eye one at a time. It is very useful for detecting anisometropia, which is the most common cause of amblyopia undetected at an early age. And it is less useful for detecting strabismus than a photo screener. This is just a chart from a Peds in Review article that was published in 2018. And it looks at some of the different types of instrument-based screenings that are available on the market, whether it's a photo screener, an autorefractor, or a hybrid, whether it looks at both eyes at once or each eye individually, what they can screen for, how much the machines cost, and how soon or how quickly you can get results. Well, let's talk about when to refer to a pediatric ophthalmologist. So during that first year of life, if a child has inconsistent fix or follow, or is unable to fix or follow by age 3 months, you should refer to a pediatric ophthalmologist. If you see a white pupil, an absent, or an asymmetric red reflex, you should refer immediately. And any ocular abnormality on external inspection should prompt a referral to ophthalmology. When kids get older, between ages 1 to 3, the same concerns during that first year of life would also be pertinent, but also if they failed an instrument-based screening test, or if at age 3, their visual acuity was less than 20/50. As kids reach 4 years of age, up to 5 years of age, if their visual acuity is less than 20/40, up to 59 months, and then if their visual acuity was less than 20/30, age 60 months or beyond. If you are doing a threshold testing and you have a 2-line visual acuity difference between both eyes, you should consider referring. Any eye movement when performing the cover-uncover test, and again, if you see a white pupil or an absent red reflex. And then finally, age 6 and older, again, as I said previously, visual acuity worse than 20/30, 2-line visual acuity difference between eyes if you're using the threshold testing, and again, white pupil or absent red reflex. Just a comment on CPT coding. Vision screening is something that you should be recording, you should be billing for, and you should be getting paid for by payers. So the vision screening code is a 99173. If you're using instrument-based screening, that code is a 99174. And these are stack-on codes. They can be used in addition to preventative medicine services. However, the one caveat is if you're seeing a patient for an acute ill visit for diagnostic reasons, in other words, they come in with an eye injury, trauma to the eye, and you do visual acuity, that then is probably going to be bundled into your E&M code and you would not bill separately. And if you're having issues getting these paid for, we please ask that you reach out to the chapter and the Pediatric Care Council, and we can see what guidance we can help you, because you should be getting paid for these. This is another sort of nice chart and summary from that Peds in Review article. And again, there's the reference if you want to go look at it, looking at what are indications for referral depending on which test you're doing, whether it's the red reflex test, external or pupil examination, the corneal light reflex, instrument-based screening, cover test, and visual acuity, and when you should consider referring to a pediatric ophthalmologist. So in closing, I just had a couple of questions for review that we'll go through together. So this first question involves a 3-year-old boy who's brought to your clinic for a routine health supervision visit. He was the product of a full-term pregnancy and spontaneous vaginal delivery. He's been followed in the same office for his health supervision visits, and he has had normal growth and development. Which of the following is the recommended method to be used to best assess visual acuity in this 3-year-old child? And the recommended answer, the right answer would be the Leah symbols, those heart, square, house, and circle optotypes. All right, next question. You're evaluating a 2-year-old boy who has Down syndrome. His mother is concerned that his eyes are turning in. In view of the fact that patients with Down syndrome have epicanthal folds and a wide nasal bridge, you want to differentiate true strabismus from benign pseudoesotropia. You'll remember I showed a picture of that earlier in the presentation. Which of the following is the most appropriate next assessment to perform in this patient to determine whether this is a true finding? Would you A, check for a symmetrical red reflex, B, check for ophthalmos, C, confirm normal visual acuity, D, demonstrate an eye-popping reflex, or E, perform the Hirschberg test? So the most appropriate answer here would be perform the Hirschberg test, which is that corneal light reflex, where you use either your ophthalmoscope or a pen light to shine a light into the eyes and look to see where that, that dot of light is compared from one eye to the other. Is it symmetrical or is it deviated one way or the other? If it's center in both pupils, then that child has benign pseudoesotropia and would not need a referral. And then our last question involves instrument-based screening. And your practice is considering the implementation of instrument-based vision screening in young children to comply with the 2016 American Academy of Pediatrics Guidelines. Which of the following is the primary goal for this screening tool? Does it A, identify retinal disorders, B, identify risk factors for vision loss, C, identify optic nerve hypoplasia, D, measure intraocular pressure, or E, measure visual acuity? And the correct response is that identifies risk factors for vision loss. Instrument-based screening will not measure visual acuity. I want to thank you for participating in this webinar, as well as participating in the Preschool Vision Quality Improvement Project. This is a program that's near and dear to my heart. It was sort of how I first got involved into the Ohio chapter about 15 years ago, giving this talk to residents throughout the state. And I would welcome any questions. There's my email address, and good luck with the rest of the project. Thank you very much.
Thank you so much.
You're welcome. So my question is, was that recording your screen or my screen?
I believe it's recording my screen.
Good.